Hello guys. So now that we are done with thorax, now we'll move on to abdomen. Okay. So in abdomen, we'll be dealing with gastroenterology and hepatology. Okay. So let us start with gastroenterology. We'll finish off the embryological part and all its anomalies here. Okay. So then we'll move on to the anatomy, physiology of gastroenterology. Then we'll go on to medicine and surgical part of the gastroenterology. Okay. So to begin with, embryology and the anomalies. So tracheoesophageal anomalies has been examiner's interest nowadays. So let us see what is it and what are the classifications. Okay, so there are 5 different types of classifications with respect to tracheoesophageal anomalies. Okay, so if there is no connection between trachea and the esophagus at all, so it is going to be the type A. If there is a connection between esophagus and the trachea and there is no connection between the stomach, it is going to be type B. Whereas so in type C, it is the stomach will be having the connection between trachea, whereas esophagus doesn't have any connection. So that is the difference between type B and type C. Okay, coming to type D is where esophagus is also connected with the trachea and the stomach part is also connected with the trachea. So this is the type D. Okay, whereas in type E, it is going to be a fistula that is being formed in the entire esophageal tract. Okay, in the entire esophageal tract, it is directly connected to the stomach, but there is a fistula that is been formed between the trachea and the esophagus. Okay, these are the 5 different classifications with respect to tracheoesophageal anomalies. Okay, the main treatment would be based on the Waterson's criteria that we do. Okay, so it is basically surgical management. Okay, so it is Cameron Heights surgery is what we do with respect to tracheoesophageal anomalies. Okay, then moving on to intestinal anomalies. So we all know that, right? So hypertrophic pyloric stenosis, since final year also we have been studying this. So hypertrophic pyloric stenosis is where the clinical features will be with non-bilious projectile vomiting will be there, because the bile has not been we aren't getting any bile, right? Because the pylorus is what is being stenosed, so that is why non-bilious projectile vomiting will be there. And during examination, there will be a olive shaped mass that will be palpable. Okay, in the abdominal region, so there will be olive shaped mass that will be palpable. Okay, so the associated risk factors will be macrolides. Okay, so if there is a early macrolides that we have infused to a baby, so it might lead to an risk of hypertrophic pyloric stenosis. Okay, so then there is hyperchloremia and hyponatremia with respect to the clinical feature of hypertrophic pyloric stenosis. Then there will be metabolic alkalosis. Okay, how do we manage the patient is, so basically we'll correct the fluids. Okay, so fluids, because nothing is passing through the stomach, right? So baby is not getting any nutrition, so we'll correct the fluids first, because there has been hypochloremia and hyponatremia. So we'll give the electrolytes through the fluids first, and then we'll go for the definitive management, that is Ramstead pyloromyotomy. Okay, so this is the definitive management. Okay, so if we take a x-ray, there will be single bubble. Okay, so single bubble will be with respect to pyloric stenosis. Okay, then on USG, it will be a donut sign that can be seen. So on USG, it will be a donut sign that we can see. Okay, so then moving on to intussusception, it is the telescoping of the intestine on one on another. Okay, so basically this is the ileum. So ileum will telescope into the cecum. Okay, so this is how the telescoping would look like. Okay, so that is why the intussusception occurs. Okay, so the clinical feature will be current jelly stools. Okay, current jelly sputum is with the Klebsiella pneumonia, right? So Klebsiella typical pneumonia will come with current jelly sputum, whereas here in intussusception it is current jelly stools. Okay, then coming to Barian enema, it is gonna look like a claw. Okay, so basically it is looking like a claw, right? Claw of a eagle. Okay, claw sign will be there. So this is how the X-ray any Barian enema would look like, and on USG it will be the target sign. Okay, so it is like a target. Okay, so just like donut only, it will be a target sign that we see in intussusception USG. Then coming to management, we are gonna do air or saline enema. Okay, so air or saline enema, and so make that make this telescope go back to its position and make it straight. So this is the management of intussusception. Then moving on to Meckel's diverticulum. There is something called rule of 2, okay, meaning 2% of the population will be affected. 2 feet from the proximal to the ileocecum is where it will occur. So it will be almost 2 inches, and it will most commonly be in 2 years of age. Then 2 types of ectopic mucosa will be there here, okay, in Meckel's diverticulum. So if it is a content of hernia, we will call it as Litter's hernia, okay. Litter's hernia, where Meckel's diverticulum, it is the content of hernia, then we will be calling it as Litter's hernia, okay. How do we do the investigation? Is based on the technetium tectinate scan is what we do it, okay. Then coming to management, what we do is basically, if it is thick and narrow opening is there, then we are gonna resect, okay. If there is thin and wide opening, we are gonna leave it as such, okay. If it is a thick, okay, we will see the Meckel's diverticulum. If it is thick and narrow, that is when we will resect, or else if it is thin and wide opening is there, so then we will leave it as such, okay. So this is with respect to Meckel's diverticulum. Moving on, so Hirschsprung disease, these are all the congenital anomalies with respect to gastrointestinal tract that we are discussing. Hirschsprung's disease, where there is a lack of Auerbach's plexus and Meissner plexus, right? So basically, these are the plexuses or the nerve supply of the gastrointestinal tract. If this particular plexus will be lost, in particularly most commonly in distal colon, is where the Hirschsprung disease will happen. Basically, there is no motility at all, okay. So there is no motility within the intestine. So what happens is, all the stool will get collected in the intestine itself, okay. So this is basically why this Auerbach's plexus and Meissner's plexus is not there, is because there is a failure of neural crushed cell migration, okay. NCC, I told you, right, all the CNS, PNS, everything will be from the neural crushed cells is what it develops, okay. So if there is no migration of neural crushed cells, so that is where the Auerbach's plexus or the Meissner's plexus will not be there, okay. Then the clinical features would be bilious emesis will be there, okay. Then failure to pass the meconium, so that is what, right. So all the stool will get connected, and sometimes there will be vomiting, which will be bilious, okay. Then if there is failure to pass meconium within 48 hours, right. So till 48 hours, we discussed in pediatrics, right. So till 48 hours it will be not normal only. It is normal for everyone, okay. But if even after 48 hours it is not passing, so that is when we'll do the investigation or examination basically. So then we'll go for diagnosis of Hirschsprung disease, okay. So abdominal, the other clinical feature is abdominal distension will be there, which can lead to congenital megacolon, okay. So this is a complication with respect to this, okay. How do we diagnose basically? So now till 48 hours the baby is not passing that stool. So what we do is, we'll do a digital exam, okay. We'll do the digital exam, and there will be expulsion of feces, okay. Expulsion of feces will be there, okay. So now after doing the diagnosis, after doing the digital exam, we'll do biopsy, okay. 2 centimeter just above the dentate line. We know the dentate line, right. So if it is the anus, there will be a dentate line, okay. So for 2 centimeter above the dentate line is where the biopsy sample is taken. This is the gold standard way of diagnosing Hirschsprung's disease, okay. What is the management? Basically, resection of that particular part of the colon is resected out. So we'll be following Duhamel and Swensen technique, okay. So Duhamel and Swensen technique is what is used for the resection of the Hirschsprung's disease, okay. Then coming to anterior wall defects, this is examiner's favorite, okay. So please remember this, anterior wall defects, okay. So mainly the thing is, so there is during the embryological genesis of gastrointestinal tract, so there will be entire midgut rotation, you know that, right. We have been learning since our first year. There will be midgut rotation that will be happening, and finally it will come to one particular position, okay. What happens is, during the midgut rotation, the gut comes out at certain particular stage, okay, comes out, and it will go back, okay, during the development. But what happens is, if the failure for the gut to go back to its during the gut rotation will lead to anterior abdominal wall defect. That is, there are three types. One is omphalocele, gastroschisis, and bladder extrophy. Okay, so please remember. So these are the certain abnormalities with respect to anterior abdominal wall. So if there is a sac along with the gastrointestinal tract, it is going to be omphalocele, whereas if there is no sac, it is going to be gastroschisis. Okay, so this is the two difference you must know. Okay, so the most commonly asked question is with regards to bladder extrophy. Please go and see image based questions of this thing. Okay, just go and see, type in Google and you will be able to see all these things: omphalocele, gastroschisis, and bladder extrophy. Okay, it was the image based question that was asked. And one more thing they asked was omphalocele, the sac is there, right? What is the covering of the sac? It is the amnion. Okay, that's it. Now coming to congenital diaphragmatic hernia, you know that, right? This is an emergency case. So basically left side is the most common. It will be Bokdalic hernia. Okay, so Bokdalic hernia will be the most common congenital diaphragmatic hernia with respect to kids. Okay, please remember it is the Morgagni hernia with respect to adults. Okay, for example, there will be a congenital diaphragmatic defect that is there, but wouldn't have been noticed since our childhood, but in adulthood, due to increased intra abdominal pressure, there might be a hernia that might be happening. So that is the Morgagni hernia, which might lead to diaphragmatic the diaphragmatic abnormality. Okay, so this is with respect to adults. Okay, whereas Bokdalic hernia is with respect to kids. Okay, this is an extra edge point, please remember this. Okay, how will the clinical features be? Basically pulmonary hypoplasia, all the intestine will go into the will herniate into the pulmonary cavity, right? So basically thorax. So that is why the lungs cannot be properly matured. So that is why pulmonary hypoplasia will be there. So it might lead to tension pneumothorax. Okay, so that is why it is an emergency case and we have to treat it. What do we do? Please do not do bag and mask. Okay, bag and mask cannot be done here. Okay, only always intubate. Okay, so directly we cannot do bag and mask because all the air might enter the gastrointestinal tract and it might exaggerate the defect. Okay, so that is the thing. Now the mainstay of treatment is reduction. Okay, so we'll reduce the hernia. Okay, the exit procedure is the procedure that we do. Okay, so this is with respect to congenital diaphragmatic hernia. Okay, so now with respect to diaphragm, coming to certain anatomies. So diaphragm, we have to know what are the openings of diaphragm and what are the structures passing through it. Please remember A, E, I. Okay, all the ovals, right? A, E, I, O, U. So basically A, E, I, remember it in that way. So A will be the lowermost, that is the aortic opening. E is the middlemost and the I will be the superior most. Okay, so first thing that will be passing in the anterior part, this is the anterior part, this is the posterior part. Okay, so this is the diaphragm. The first opening will be IVC. Okay, so IVC, here the right phrenic nerve will also be passing through it. Okay, so remember this. Then coming to E, it will be the esophagus and the 10th cranial nerve, that is the vagus nerve, that will be passing in the middle. Okay, then coming to the posterior most and the last most, that is the aortal opening. So where along with it thoracic duct, azygous vein and the hemiazygous vein will be passing through it. Okay, so this is the diaphragmatic openings and all the structures that are passing through it. Okay, now coming to anterior abdominal wall. So please remember umbilicus dermatome will be T10. Okay, so T10 will be the umbilicus dermatome. Okay, neurovascular bundles lies in between the internal oblique and the transverse abdominis. Okay, so please remember this extra edge point with respect to abdominal wall muscles. Okay, so where will the neurovascular structure or the bundles that will lie, that will supply the muscles, is between the internal oblique and the transverse abdominis muscle. You know that, right? There are three muscles in the abdomen, that is external oblique, internal oblique and the transverse abdominis. It is the second and the third muscle. Between that is where the neurovascular bundles lie. Okay, then coming to the defect of anterior abdominal wall, that is hernia. Okay, so we'll discuss about hernia now. So there are two types of hernias, right? So there are there are many types of hernia, but in inguinal hernia there are two types. Okay, there is something called femoral hernia, buccalic hernia, all these things are there, right? So basically the abdominal content is coming out. So is what hernia means, right? So through a weak abdominal wall. Okay, so there is going to be inguinal hernia where there are two types, that is direct hernia and the indirect hernia. Okay, so the thing is in inguinal, basically let us see the inguinal anatomy. So basically inguinal anatomy is just 4 centimeter. Okay, so there is a canal just below the anterior abdominal wall and between the inguinal ligament. So there is a canal. Okay, so through which the so basically what happened is during embryogenesis, during the fetal development, the our gonads will be an internal abdominal organ. Okay, so from internal abdominal organ it is coming to the scrotum. So this is what happens during development. Okay, so that is why this canal is there. Okay, so this canal was to pass the gonads to the scrotum. What happens is sometimes this canal, from there is where the cords and all are connected to the prostate and all, right? So what happens is sometimes this wall or the walls of the hernia might be defected with respect to the superficial ring and the deep ring. Okay, so there is two valves, right? That is superficial and deep valve is there. So there might be a defect when there is weak abdominal wall, when there is a increased intra-abdominal pressure, which might lead to the internal abdominal organs to herniate through this particular canal. So that is what inguinal hernia means. Okay, so this particular canal is basically 4 centimeter. Okay, then what are the contents of inguinal canal is basically spermatic cord. Okay, spermatic cord with respect to male, and in female it is going to be the round ligament. Okay, so what is round ligament and all we'll see in the obstetrics. Okay, so round ligament in female, whereas spermatic cord with respect to male. Okay, so and also the inguinal nerve. Okay, inguinal nerve is not a content of spermatic cord, please remember this. Okay, so this is a question. Okay, so this is a previous question they have asked. Okay, which is not the content of spermatic cord. Okay, but it is a content of inguinal canal, but it is, see, spermatic cord is passing and right next to it the inguinal canal, the ilio-inguinal nerve is also passing. Okay, it is a content of inguinal canal. Okay, now please note there is something called as myopectineal orifice. Okay, myopectineal orifice and Hasselbalch's triangle, which is very important. Okay, meaning if the triangle would be formed by rectus abdominis, inguinal canal and the inferior epigastric artery. Okay, so this is the weakest part of the anterior abdominal wall. So Hasselbalch's triangle is where the direct hernia can happen. Okay, these are the weak areas of the anterior abdominal wall, both of this myopectineal orifice and the Hasselbalch's triangle. Okay, from inside, okay, there is something called as triangle of Doom. So now basically we are discussing some related anatomy with respect to hernias. Okay, so there is something called triangle of Doom, which we can see when we are doing laparoscopic. Okay, when we are doing a laparoscopic surgery for hernia, there is something called triangle of Doom. Okay, so here the boundaries are formed by the vas difference, and on the lateral will be the vasculatures will be there. Okay, so this is the triangle of Doom that will be formed. Okay, the reason why it is important is, so here is where the external iliac vessels, okay, external iliac vessels will be in the triangle of Doom. Okay, so that is why when doing the surgery we should always be taking care of this particular triangle of Doom. So that is why it is very important. From inside this is the triangle that we'll be seeing, but from outside it is the Hasselbalch's triangle that is very important. Okay, with the weakness. Then with the respect to hernia, so how are they going to present with the clinical features is basically swelling will be there and cough impulse will be there. Okay, swelling and cough impulse will be there. So basically the patient presents to you with a swelling. Okay, then coming to pain, there won't be pain. Okay, so there will be dragging sensation will be there in people, but pain will occur only when there will be strangulation or obstruction. Okay, so when there is strangulation or obstruction, that is the severe case, that is when the pain will occur. Okay, So always there will be mild dragging pain, okay, mild dragging or colicky pain will be there, but here the severe pain will be there with respect to strangulation or herniation, means obstruction, okay. So some of the important hernias are Richter's hernia, pantaloons hernia, litters we saw, right? Meckel's diverticulum, then sliding hernia, Meidel's hernia, which looks like a W. These are some of the important hernias, okay. Then coming to management, okay, if it is umbilical hernia in kids, what we are going to do is, so if it is less than 2 centimeter and if the child is less than 5 years, if we are going to observe the patient, okay. If it is more than 2 centimeter and if it is more than 5-year-old kid, we are going to do a procedure called myo procedure, okay. Basically we are tightening the muscles, okay, with respect to umbilical hernia. This is what we do with respect to umbilical hernia in kids. Now the surgery with respect to congenital hernia is basically herniatomy, okay. Herniatomy is what we do with respect to congenital hernia. Then there are different types of procedures that we do. These are the named surgeries are, so Bessini, okay. Here what we do is conjoint tendon suture to the inguinal ligament. So basically all this is basically what we are doing is tightening and increasing the strength of the abdominal muscles, anterior abdominal muscles. So what we do in Bessini is basically conjoint like suturing the conjoint tendon to the ligament, okay, in inguinal ligament, okay. So that will strengthen the inguinal ligament and the weakened canal, okay. So then coming to Scholdeis surgery, we are gonna be double breasting the transverse fascia, okay. So double breasting the transverse fascia. Then coming to a strip from the external oblique muscle, this is the Desarda technique. Then Lichtenstein mesh repair, you know that, right? This is the famous, this is what we do now, okay. So this is the these are all the old techniques that we used to do, but now the best method is Lichtenstein tension free repair is what we do in all the hospitals, okay. There is a new procedure called Stoppa's method. Please remember this Stoppa's method, where there is a large mesh that is placed, okay. So Lichtenstein tension free is also mesh placement only, but it was a small mesh only in the place that there was defect, the mesh was being placed, but in Stoppa's there is a large mesh that is being placed, okay. So that is Stoppa's surgery. Please once again before going to the exam, please take a look at this, okay. So I told you, right, the strangulated hernia will be having excruciating pain. So that is why it is an emergency, okay, where there will be vasculature will be affected. So that is why it is an emergency surgery. So here we do MEDBUDDY's procedure, okay. So this is with respect to strangulated hernia. There is something called onlay, inlay and retromuscular procedure, where so if it is a umbilical hernia that is happening with respect to adults, so this is the places where we place the mesh, okay. So this is the placement of mesh in incisional hernia. Basically if a incision has been done and suppose for some other abdominal surgery and there is a hernia that is happening, this is where the meshes will be placed, okay. Onlay, inlay and retromuscular, okay. So these are the places. Now coming to peritoneum. So anterior abdominal wall is done. So now we'll go on to peritoneum, okay. So there are certain ligaments that is very important. Please go through this table, okay. So there are certain ligaments that are important. So there is nothing for me to teach here. This is all memorable stuff, okay. So please go through this ligaments, okay. So the important pouches I'll teach you, okay. So there is some of the important spaces that we are supposed to know. That is the Morrison's pouch will be the hepatorenal pouch. Here all these pouches are there, right? So here the abscesses and all the collection of the fluids might happen. So that is why it is important to know these pouches during a ultrasound, okay. So this is what we look for. So hepatorenal pouch between renal tissue and the liver. So there is something called as Morrison's pouch and pouch of Douglas, we know that, right? Rectouterine pouch. Many of the cancers, abscess and probably endometriosis and all will happen here. Pouch of Douglas. Then there is something called as Hartmann's pouch with gallbladder. Then subhepatic space. Okay, subhepatic space is the most common site of abscess for liver, okay, and peritoneal abscess is the here is where the most common site is, subhepatic space, okay. Now coming to general gastrointestinal tract proper anatomy. So these are the layers of gastrointestinal tract, that is mucosa, submucosa, muscularis and serosa. Okay, this is the thing. So coming to Meissner's plexus, this is what controls the secretions will be present in the submucosa. Okay, then coming to myenteric plexus, that is what we learned, right? The Auerbach's plexus and the myenteric plexus, which maintains the motility, will be in the muscularis layer. Okay, so it basically all the nerves will be supplying the muscles, right? So that is why muscularis layer. So please remember an extra edge point of serosa. In esophagus there will be no serosa. Okay, it will be only mucosa, submucosa and muscularis. So that is why cancer of cervix, cancer of the esophagus is very aggressive. Okay, because it can there is no serosa, so that is why it can become malignant. There is no basal membrane and it can travel to anywhere and become malignant. So that is why it is very aggressive. Please, this is an extra edge point. Okay, so how do you differentiate between small intestine and large intestine? Is there is a valvula communis. Okay, please see an image of it, valvula communis, okay, with respect to small intestine, whereas large intestine there is host race. Okay, when we take a look at large intestine, these host race will be there, right? So this is how we differentiate. It is small intestine and large intestine. Okay, please remember, how do we differentiate cecum from the large intestine? Is there is no appendices epiploicae with respect to cecum, but in other large intestine there will be appendices epiploicae. So that is how we differentiate cecum from a large intestine. Okay, then the major arteries that are present with respect to gastrointestinal tract is foregut, midgut and hindgut. So three different parts of gastrointestinal tract. Foregut will be having the arterial supply from celiac artery, then midgut from the superior mesenteric artery, and hindgut will be inferior mesenteric artery. With superior mesenteric artery, there are clinical significance, that is nutcracker syndrome, SMA syndrome and watershed area with respect to splenic flexure. Okay, so meaning, so what happens is in SMA versus IMA, so SMA will be this is the splenic flexure. Okay, so this is the transverse colon, this is the descending colon. So this is the splenic flexure, here is the spleen. Okay, so this is why that is why the name splenic flexure. What happens is, till the transverse colon ending, so there will be the SMA that is supplying, and after the transverse colon ending, so it will be the IMA that is supplying. But here in this zone there is no blood supply at all. So that is why it is basically getting its collaterals from these two arteries. But suddenly if there is a issue or some damage with the collaterals, so it might go to gangrenization. Okay, so there might be necrosis. That is why the watershed area is very important with respect to SMA. Okay, so that is with respect to arteries. Now we'll go on to GI physiology, a little bit basics, and then we'll go on to the different GI pathologies. Okay, so coming to GI physiology, all the secretions and actions are important with respect to all the different regions. See, mouth, all the secretions, so stomach there is secretions, duodenum, pancreas, and all these things will be having certain secretions. Okay, so please go through this table and it will be helpful for you. Okay, so please go through this table. There is nothing for me to explain again, so it is all about memorization. Okay, then now coming to GI motility. So please remember, there is slow waves. Okay, so the slow waves are the GI motility waves. Okay, so it is maintained by the interstitial cells of Kajal. This is the pacemaker. Okay, so basically SA node and AV node were the pacemakers in heart, right? So in the same way, interstitial cells of Kajal are the pacemakers of GI motility. Okay, so the least frequency will be seen in stomach, whereas the maximum frequency will be with the ileum. Okay, because least frequency, why? Because stomach has to store for a little while and the digestion has to go on, whereas ileum, it is all about absorption and it has to push the bolus outside, right? So that is why in ileum the maximum frequency is there for peristalsis. Okay, then coming to interstitial cells of Kajal, let us see the mechanism of activity. What happens is, so during fasting there is migratory motor complex, okay, which causes the that is motilin. What happens is, it will push out, or the peristalsis is so strong, it will push out everything and push it out of the anus. Okay, so this is during the fasting. Okay, whereas during feeding, there are two things that is happening. Okay, one is segmentation, another one is peristalsis. Segmentation helps in breaking down of the food. Okay, so segmentation will help in breakdown of the food, whereas peristalsis will help the movement of food forward. Okay, so from one end to the other end is what the peristalsis is doing. Okay, so how does it do is, from one end it will push, right? So one, this is a intestine, and from one end it is pushing, meaning there will be contraction. This contraction is caused by substance P and acetylcholine, whereas on the other end there should be relaxation, right? So the food can come in, so that is where the nitric oxide and VIP, okay, vasointestinal peptide will act on and relax it. So this is the main action with respect to interstitial causal cells. Okay, that is the pacemaker. So please remember, the urge to defecate will be at 18 mm Hg. Okay, this is the pressure when this generate, that is when we get to get the urge to defecate. Okay, so this is all and everything you need to know with respect to physiology, GI physiology and anatomy and embryology. Okay, so now we'll move on to the pathologies, all the medicine pathology and the surgical pathologies with respect to each zones, that is esophagus, stomach, then small intestine and large intestine, then till the anus. All the pathologies we'll see one by one. Okay, so starting with esophageal pathologies, it is the achalasia cardia. Let us discuss about it. So achalasia cardia is basically a failure to relax the lower esophageal sphincter. Okay, so lower esophageal sphincter is not able to getting relaxed. So what happens is, all the food that we eat will be accumulating here itself in the esophagus. Okay, so there are two causes, that is the primary and secondary causes. Remember Chagas disease, right? So this is the secondary cause for achalasia cardia. Okay, Chagas disease, we had learnt it in microbiology, right? Trypanosoma cruzi, okay, kissing disease. So that is the thing. Okay, so there are classification, three types of classification, that is Chicago classification that we do. So the three main types are the classic, the vigorous and the spastic type. Okay, so these are the main three types. Okay, classic type, the vigorous type and the spastic type. Okay, then the clinical feature is basically, I told you, right, all and everything that we eat will be getting accumulated here in the esophagus. It will be, so please see the particular clinical feature here. The difference or the difficulty for liquid will be more than solid. Okay, so here for liquid it will be more than as we see for solid in case of achalasia cardia, because more difficulty for solid as compared to liquid will be with respect to cancers. Okay, so esophageal cancer, that is the thing. So that is why this difference must be addressed. Okay, then coming to investigation, what we do is basically manometry. So basically we will see the pressure that is there in the end of the esophageal sphincter. So based on manometry only we will be treating the disease. Okay, then what we do is barium meal studies. So in barium meal, so we will get to see bird beak appearance. Okay, and then coming to management, it is the botulinum toxin. What does botulinum toxin do? So basically the acetylcholine surge, right? So what it does is, it will basically relax. Okay, so it will be relaxing the end esophageal end. Okay, so botulinum. Then coming to particular that specific treatment will be Heller's myotomy. Okay, so we'll basically cut off that particular muscle. Okay, so then we also have developed something called as Poem's procedure. Okay, so this is the specific management of achalasia cardia. Okay, then there is something called as nutcracker's esophagus, where also called as a distal esophageal spasm, where there is increased duration of peristalsis. Okay, so increased duration of peristalsis, which will cause increased spasm in the esophageal sphincter. Okay, so this will have a specific pain, just like chest pain. Okay, so when we do a barium swallow, so we'll get to see corkscrew like appearance. So corkscrew like appearance will be there. Okay, so this is the specific with respect to nutcracker esophagus. Okay, there is something called Schatzki's ring. Please go and see an image of Schatzki's ring. Okay, so Schatzki's ring, image based question might come, so just go and identify that Schatzki's ring. Okay, now coming to gastroesophageal reflux disorder. See, in achalasia cardia, what happened was, the esophageal sphincter was too much spasm was there and it was not opening at all. But here in GERD, there is no tone in the esophageal sphincter and it is always open. So that is the major difference, okay, with respect to GERD. So there will be less tone in esophageal sphincter. The clinical features will be heartburn, regurgitation and dysphagia, okay, because all the food that we eat will go to stomach, but it is regurgitating back into the esophagus. So that is why GERD will be having regurgitation and heartburn, okay. So the complication might be erosive esophagitis, stricture might happen because all the acids are coming back to the esophagus. And the major thing is Barrett's esophagus, okay. So there might be Barrett's esophagus where there will be dysplasia, right. So there will be dysplasia which might lead to cancer. Highest cancer risk will be there with respect to Barrett's esophagus, okay. So how do we do the investigation is basically we'll monitor 24-hour pH monitor, because here in esophagus it should be basic, but as the acids are coming from the stomach, the pH will be reduced, okay, and it will be acidic, okay. So that is the pH monitoring that we do, and we'll do something known as Dempster scoring, okay. So that is how we diagnose GERD, okay. What will be the treatment? So before the specific management, so the basic treatment, the first treatment, the management will be protein rich meal. So protein rich meal will reduce the acid secretion. So that is how the GERD can be treated before the specific management, okay. Then coming to esophagitis, there are different kinds of esophagitis. Please go and see the image based identification of each of the esophagitis, okay. So then coming to Plummer-Vinson syndrome, there is a triad, okay. Plummer-Vinson syndrome has a triad, meaning esophageal web will be there, dysphagia because of that esophageal web will be there, then there will be iron deficiency because nothing is reaching the stomach, okay. So this is how the Plummer-Vinson syndrome will be presenting with the triad: esophageal web, that is why the dysphagia is there, the iron deficiency, anemia will be there. Then coming to Mallory-Weiss tear, so this is basically partial thickness, longitudinal laceration of the gastroesophageal junction, okay. So in near the so this is the stomach and this is the esophagus, right. So what happens is there is a longitudinal tear in this particular area because of increased vomiting. So suppose if there is a chronic vomiting, and in alcoholics and all, this might happen. So where there is increased pressure that is being applied with respect to the junction, so that is where the Mallory-Weiss tear might happen, okay. So this is of increased risk in respect to alcoholics, okay. Then the esophageal perforation, so it is basically most probably it is because of iatrogenic cause. Some endoscopy might have torn, or some of the drugs or some of the alkali ingestion can lead to perforation. So the clinical features will be, it will be pneumomediastinum, because the esophagus is perforated, all the air that is coming from the mouth is passing into the mediastinum, because esophagus will be in the mediastinum, right. So that is why pneumomediastinum. Then subcutaneous emphysema will be there, okay. Subcutaneous emphysema will be there. Then Boerhaave syndrome, meaning there will be due to violent retching will lead to Boerhaave syndrome, okay. So this is the clinical feature with respect to esophageal perforation. How do we diagnose is basically contrast esophagogram will do, and we'll see where exactly the perforation is, okay. Then what we'll do is basically omental patch, okay. We'll do a omental patching that we do for the management of esophageal perforation. Then coming to Barrett's esophagus, okay, so we discussed, right, it is basically a complication for GERD. So basically I told you, right, so there is a metaplasia and dysplasia that is happening, so where the squamous cell is being converted into the columnar cell, okay. Squamous cell is the particular cell of the esophagus where it is getting metaplased into columnar cell, okay. So Z line is very important with respect to Barrett's esophagus, is where the demarcation that we do, okay. Then investigation will be methylene blue stain. So by applying methylene blue stain, we can know that what type of histological changes that is happening. Okay, so this is methylene blue that is using used as a stain. Then coming to management, it is going to be the ablation of the abnormal mucosa. Okay, so basically we are ablating the abnormal mucosa that has been newly formed, and endoscopy every 3 months is done because there is an increased risk of carcinoma esophagus. Okay, so that is why we'll do endoscopy every 3 months. Okay, then coming to the specific, that is carcinoma esophagus. So there will be progressive dysphagia, that will be the main clinical feature, and there will be weight loss. I told you, right? So it is a aggressive carcinoma because there is no submucosa in esophagus. So upper 2/3, okay, squamous cell carcinoma is basically what is involved here. So we can see with respect to alcoholics, okay, and hot liquid is what might be the risk factor. Okay, with respect to upper 2/3 esophageal carcinoma, whereas lower 1/3 carcinoma, it is probably adenocarcinoma. Okay, so because of GERD, I told you, right, GERD might cause Barrett's esophagus, and it might turn into a complication of esophageal cancer. Okay, the clinical feature is I told you, right? So in achalasia cardia, the difficulty was more with liquid than solids. Okay, but here it is the solids that is having more difficulty than liquids. Okay, so solid passage is more as compared to liquids here. Okay. Then coming to classification, there is a Sievert's classification, that is 1, 2 and 3. 1 is proximal, whereas 2 is the gastrointestinal junction and the distal most if it is affected. So basically if this is the esophagus and this is the stomach. Okay, so if it is proximal most, then it is the type 1, and G junction if it is there, then it is type 2. Then if it is the distal most part of the esophagus, then it is type 3. Okay, so this is the Sievert's classification. So that is all with respect to pathologies of esophagus. Okay, now we will monitor the pathologies of stomach. Okay, so in stomach, it is gastritis. Okay, so gastritis is very important. There are two types of gastritis: acute gastritis and chronic gastritis. So the acute gastritis will be caused by NSAIDs. Chronic NSAID intake will cause the prostaglandins to be decreased, and there will be reduced gastric mucosa. Okay, so that is when the acids will start destroying the gastric mucosa, right? So then the burns, and if there is brain pathology. Okay, so in burns there will be curlings, ulcers, whereas in brain, and if there is a stress, okay, so if there is stress pathology, then it is going to be Cushing's. Okay, so that is the acute type of gastritis. Okay, then coming to chronic, it is going to be mucosal inflammation and atrophy that is happening. Okay, so this is because of two types, that is type A and type B. Okay, if it is autoimmune, it is known as type A. If it is H. pylori that is causing it, it is going to be type B. Okay, so type A, so what happens is basically it is autoimmune, right? So it destroys the hydrogen potassium ATPase on the parietal cells. Okay, which will reduce the which will increase the acid production and cause the gastric mucosal inflammation and atrophy. Okay, so it is the body and the fundus that is involved most commonly with respect to type A. Then coming to type B, it is basically the peptic ulcer will be formed by the H. pylori, right? And the most common site that is affected is antrum. Okay, so antrum is the most common site that is affected with respect to type B. Okay, please remember this types. Okay, type A and type B. Then the risk of malt lymphoma will be high in respect to H. pylori, that is type B. Okay, the investigation that we do is non-invasive test and invasive test. With respect to H. pylori or the peptic ulcer, what we do is there is non-invasive and invasive investigations that we do. Non-invasive is we'll do urea breath test and stool antigen is what we do, whereas in invasive we are going to do rapid urease test. Okay, this is the invasive method of investigating the peptic ulcer basically. Okay, so how do we treat? So basically bismuth quadruple therapy. Previously it was a triple therapy that we used to do, but now it has been changed to quadruple therapy. Bismuth quadruple therapy is what we do. So basically what we use is PPIs, bismuth preparation, then the metronidazole and tetracycline is what we use. Okay, so please remember this quadruple therapy is what we use for peptic ulcers. Okay, then the surgical method of management is in chronic gastritis. So it is going to be fundoplication. What we do is the Nielsen's surgery, meaning the 360-degree of fundoplication is what we do. Top-edge surgery is 270-degree, and door surgery will be 180-degree anteriorly. Okay, so this, please go and see a image based thing with respect to these fundoplications. And also we can do vagotomy. Okay, so vagotomy can also be done, okay, to decrease the acid secretions. Okay, so these are the things that we can do with respect to gastritis. So now coming to Mentrier's disease. So this is basically hyperplasia of the gastric mucosa. Okay, so how it looks like is basically it looks like a rug. Okay, so it looks like a rug that has been folded too many times. So this is the Mentrier's disease. What happens is there is hypertrophied rugae, which will cause the excessive mucus, okay, secretion, which will reduce the acid production, and there will be protein malnutrition, because see, acid is required for protein degradation, right? So if the protein degradation is not happening, there will be protein malnutrition, which will lead to weight loss, edema, because amino acids is required for albumin production. If there is no albumin production, it might lead to edema. Okay, so this is the thing with respect to Mentrier's disease. Please see an image of Mentrier's disease stomach. Okay, so there will be hypertrophied rugae, you can see. Okay, so here please note that antrum will be spared, okay, where the body and fundus will be the most common site it can occur. Okay, so investigation is basically we'll take a full thickness biopsy. Okay, then the management will be cetuximab and gastrectomy. Okay, because it might lead to gastric cancer, so that is why we will have to do gastrectomy. Okay, so this is with respect to Mentrier's disease. Okay, now coming to the specific, that is gastric carcinoma. Adenocarcinoma is the most common type of carcinoma. So it is early, aggressive, and local spread will be there. So gastric carcinoma, you know that, right? It is very fatal. Okay, so it is very fatal. It will be early, aggressiveness will be there. Then coming to clinical features, so weight loss will be there, satiety, abdominal pain, and obstruction like symptoms will be there with respect to clinical features. Okay, so metastasis can happen. So this is where we get to see the clinical features, that is Virchow's node. That is Virchow's node is we'll be seeing in supraclavicular lymph nodes will be enlarged. Then the sister Joseph nodules in the umbilicus is what we'll see. Then Krukenberg tumor. Okay, so these are the some of the extra symptoms that we can see with respect to gastric cancer. Okay, the classification ways, many types of classification is there, but please remember the Bormann's and Lawrence. In Lawrence classification there are two types, the intestinal type and the diffuse type. Okay, so intestinal type is caused by H. pylori, and increased smoking will lead to intestinal type of gastric carcinoma, whereas it is the E. cadherin mutation which causes the diffuse type of carcinoma. Okay, then the clinical features will be ulcer. Okay, so it is the ulcer like thing will be there with respect to intestinal, because H. pylori, right? H. pylori will cause the peptic ulcer, and from ulcer it might lead to cancer. Okay, so that is the thing with respect to intestinal. Whereas diffuse, the clinical feature will be diffuse, cross thickening will be there, and leathery. So that is why I told you, right? So we'll take a in Mentrier's disease, we'll take a full thickness biopsy to rule out whether it is diffuse type of gastric carcinoma is what we are trying to rule out with respect to gastric carcinoma. Okay, so that is all. Then that is all the pathologies with respect to stomach. Okay, so now we'll move on to the duodenal pathologies. Okay, so here in duodenal pathologies, the main thing is ulcers, right? So the peptic ulcers. Okay, so now I was telling about gastric ulcers, right? That the H. pylori and all. So we'll have to differentiate between duodenal ulcer and gastric ulcer. So what happens is, in gastric, how do we differentiate whether it is happening in duodenum or in the stomach is, so if there is increased pain after a meal, so it is going to be gastric ulcer. Okay, if the pain decreases after a meal, then it is going to be duodenal ulcer, because see, if we after a meal intake, there will be increased acid secretion, which will cause the increased surge of clinical features. Okay, and the pain, heartburn and all will be there. Whereas when the when there is a duodenal ulcer, so what happens is, if the meal comes in, there will be increased mucus production within the duodenum itself. So that is why it will relieve the symptoms. So pain will decrease in the with respect to meals. Okay, so this is the difference between duodenal and gastric ulcer. So gastric ulcer, we know that, right? H pylori will cause 70% of it, and NSAIDs will cause the risk because COX inhibition is happening. And here also it is H pylori, 90% of it will be the H pylori. Then there is something called as Zollinger-Ellison syndrome, which might that is the gastrinoma cancer, which might lead to duodenal ulcer. Okay, then there is increased risk of cancer. Just now we discussed it, the intestinal type of cancer might occur with respect to H pylori. Then with respect to duodenal cancer, it is duodenal ulcer, it is going to be benign. Okay, so there is no risk of cancer. So it is the antrum and lesser curvature that is most commonly involved, whereas it is the first part of duodenum that is most commonly involved with respect to duodenal ulcer. Okay, what are the complications of ulcer that might happen is hemorrhage, obstruction, and perforation. Okay, in perforation, anterior perforation is most common than posterior perforation. How will the perforation present with is basically guarding, rigidity, and septic shock might be the presentation. Okay, so investigation is basically X-ray. There will be air under diaphragm. Please see air under diaphragm. It is an image based question, the previous year question. Okay, previous year they have asked many a times. So air under diaphragm, if you see, there is a perforation that is happening within the intestine. Okay, so that is the thing. Then coming to management, it is going to be basically IV fluids will be given, the Riles tube will be introduced, and antibiotics can be given. So post antibiotics, we can directly go for laparotomy. Okay, so here in laparotomy, what we do is basically modified Graham's omental patch. There also in esophageal perforation, we did the omental patch, right? So here also the same thing, but here it is the modified Graham's omental patch is how we manage the perforation. Okay, then coming to acute GI bleeding, please remember, how do we differentiate whether it is the upper GI bleeding that is happening or the lower GI bleeding that is happening? So upper GI bleeding, it is basically proximal to ligament of Treitz. Okay, there is something called ligament of Treitz in the foregut. So that is how we differentiate between the upper GI bleeding and the lower GI bleeding. If it is proximal to that particular ligament, it is going to be upper GI bleeding. So here how we differentiate is, it is basically hematemesis or melena. Okay, so black stool will be there because to pass from above till down, it is gonna take time, and the hemosiderin degradation is happening, and all the blackening will happen with respect to the blood. Okay, so that is why melena. But here in lower this one, so it is going to be distal to ligament of Treitz, which will lead to hematochexia, that is bright red stool. Okay, so because it is below, easily the blood is coming out, so there is no time to break down the blood. So that is why bright red stool can be seen with respect to lower GI bleeding. Okay, so now coming to diarrhea, there are two types of diarrhea, that is osmotic diarrhea and secretory diarrhea. Osmotic diarrhea, it happens because of poor absorption of the osmotically active substances, whereas secretory because of the secretions that is happening from the gastrointestinal mucosa. That is majority, it will be sodium chloride and bicarbonate secretion that is happening with respect to diarrhea. Diarrheal microorganisms and all we studied in microbe, right? So microbiology. So this is very important. Okay, diarrhea, all the E. coli and all the other protozoans and all we studied, right? Please go through that once again, you would have definitely forgotten it. Okay, so now coming to IMNCI guidelines, we also studied IMNCI guidelines with respect to pneumonia, right? So that was no pneumonia, pneumonia, and severe pneumonia. Here also it is going to be with respect to diarrhea is no dehydration, some dehydration, and severe dehydration is how we divide the IMNCI guidelines into. So basically it is because how we manage is why we divide them into. So plan A, plan B, and plan C. Okay, so in plan A, what we are going to do is, it is a OPD based treatment, that is ORS and zinc is what we are going to tell the mother to do. And coming to plan B, it is the same thing, ORS only 75 ml per kg in 4 hours is what we are going to do. This is SOS, whenever needed is when what we give for plan A, no dehydration, whereas some dehydration is there, every 4 hours we are going to give. Okay, so definitely we are going to give, it will be 75 ml per kg is the dosing Whereas in plan C, severe dehydration is there. That is why we'll admit and we'll do the IV fluid. Okay. In phase 1, it is going to be 30 ml per kg we are going to give. So ringer lactate is the solution. In the first hour, there is going to be phase 1. Whereas in phase 2, it is going to be 70 ml per kg ringer lactate solution. In 5 hours, we are going to give. Okay. So this is the IMNCI guidelines with respect to diarrhea treatment. Okay. So basically the dehydration status is how we divide it into. Okay. So then coming into after the duodenal pathologies and all, so now we'll go on to small intestine and large intestine disorders. Okay. So this is with respect to intestinal bowel disorders. Okay. So the major differences between Crohn's, ulcerative colitis and celiac disease is what our focus is. So in Crohn's, it is the transmural affection that is happening. Okay, so all the layers of the gastrointestinal tract is affected in with respect to Crohn's, whereas ulcerative colitis, it is only the first layer, that is the mucosa, that is being affected. Okay, so I'll come back to celiac disease later. So Crohn's and ulcerative colitis will focus on. Okay, so Crohn's is a autoimmune disorder, whereas ulcerative colitis is also an autoimmune disorder. The risk of Crohn's disease will increase with smoking, whereas surprisingly there is a decreased risk of ulcerative colitis with respect to if someone is smoking. Okay, so it is the HLA-B27 that is affected. HLA-B27, remember, right, all the anti-rheumatic anti-rheumatic diseases were HLA-B27, right? Ankylosing spondylitis, psoriatic arthritis and all these things, right? So HLA-B27 is involved. Then the Crohn's disease will be from mouth to anus, it can affect, whereas it is rectum that is most commonly affected with respect to ulcerative colitis. That is why colon, if the colon, right, rectum is also a colon. So then it extends proximally, not distally. Okay, so proximal, if rectum is involved, so it will start going above. Okay, so that is how the difference is between Crohn's and ulcerative colitis is. So when we see an endoscopy, it is going to be cobblestone appearance that will be there, and there will be skipped lesions. Okay, skip lesions will be there. Okay, so it is not continuous, it is going to be skipped, one skipped lesions will be there all along when we do the endoscopy. Whereas in ulcerative colitis, it is going to be continuous lesion that we can see. One of the extraintestinal observation is that is aphthous ulcer. Aphthous ulcer around the mouth will be seen with respect to Crohn's disease. This is one of the earliest feature of Crohn's disease. Please note this, aphthous ulcer. Okay, so the other extraintestinal features are uveitis, arthritis, erythema nodosum and all can be the extraintestinal features with respect to Crohn's. Whereas arthritis, okay, so I told you, right, HLA-B27 is involved, meaning there might be there might be psoriatic arthritis and all. So this can happen. Then bleeding will be occasional in Crohn's disease and common with respect to ulcerative colitis. The management will be steroids, the mainstay of treatment. Then the immunosuppressant and biologics can be used. Whereas here in ulcerative colitis, it is the 5-ASA, that is sulfasalazine is what is being used. Okay, after that we'll go for steroids therapy and anti-TNF, that is infliximab can be used. Then tofacitinib. Okay, so please note everything. Okay, so this is very important with respect to ulcerative colitis treatment. Okay, then the post surgery, if there is a surgery that is being done for Crohn's surgery, Crohn's type, what we'll do is we'll give cholestyramine, which will help the bile reabsorption. Okay, so bile reabsorption, it will help. Okay, and reduce the water secretion that is happening. Okay, because post surgery there might be increased diarrhea that is happening. Okay, so that is why we'll give cholestyramine. So please remember this. Okay, so complication is basically after resection, bowel, even before resection, short bowel syndrome, because all the layers of the intestine is affected. Where will the absorption of nutrients will go into, right? So nothing is getting absorbed. So that is where short bowel syndrome might occur. Okay, so only certain of the intestine might be spared. So that is where the absorption is happening. So this will lead to short bowel syndrome, right? So that is the thing with respect to Crohn's disease. Whereas acute exacerbation of ulcerative colitis is known as true Lown-Witts criteria. Okay, so acute exacerbation will be basically more than 6 bloody stool or toxic signs might be there. Okay, so this is known as true Wolfowitz criteria. Okay, so this is the thing with respect to ulcerative colitis. Okay, now coming to celiac disease. So basically celiac disease, there is a gluten ingestion issue, right? So if someone takes gluten, he'll be getting inflammatory bowel syndromes. So basically there is villus atrophy that is happening. It is also an autoimmune disease where the gluten diet is affecting it. Okay, so HLA DQ 2 and 8 is what is being affected, whereas it was B27 in ulcerative colitis. Duodenum and jejunum is most commonly involved. Scalloping of the folds can be seen in endoscopy. Okay, but diagnosis is by xylose test. Okay, D-xylose test. Okay, one of the extra intestinal features is dermatitis herpetiformis. We talked about this in dermatology, right? So please note this down. Dermatitis herpetiformis, please note this down in your sticky note. This has been asked hundreds of times with respect to celiac disease, dermatitis herpetiformis. Okay, and then the bleeding will be rare in celiac disease. So what is the mainstay of treatment is gluten-free diet. Okay, so this is celiac disease. All the IBD is done. Okay, inflammatory bowel diseases are done. So coming to the last part of the intestine, that is appendicitis. Okay, appendicitis. Okay, so what are the features the appendicitis patient will present with? Nausea, vomiting, right lower quadrant pain, and radiating to umbilicus. Okay, then what are the appendix positions? So you know that, right? So many appendix positions are there. So retrocecal, okay, so post-ileal, and all these things are there. The most common position is retrocecal position. Okay, okay, then this is where the appendicitis might happen most commonly. Okay, so diagnosis is based on but the point tenderness. Okay, so McBurney's point tenderness, we would have all elicited this, right? So McBurney's point tenderness is where the pain will be. And a rousing sign, what does that mean? So basically pain in the right lower quadrant when we will be palpating on the left lower quadrant. Okay, so when we are palpating on the left lower quadrant, the pain will be there in the right lower quadrant. Okay, so this is known as rousing sign. Okay, then we'll do some for the management, we'll do something known as Alvarado scoring, Mantrel, you remember, right? Mantrel scoring. So there are 10 points given to it. So based on the points that they score is how we manage. Okay, or we decide whether whether there is appendicitis or not. Okay, what we do is, so 1 to 4, if the score is there, there is unlikely appendicitis. Okay, then if it is 5 to 8, it is going to be probable. Then 9 to 8 is appendicitis definite. Okay, so definitely appendicitis is there. So this is how we diagnose the appendicitis. Now coming to management, so the investigation that we do is ultrasound, right? So first, whenever the patient comes to you with appendicitis pain, what we'll do is we will get one ultrasound. So that is where when we are on the Doppler, so basically Doppler is when we get to see the color, right? Color around the certain substance. So when color is on, so we'll see ring of fire appearance. Okay, ring of fire appearance. This we will be seeing also in ectopic pregnancy. Ring of fire appearance can be also seen in ectopic pregnancies. Please remember this. Okay, then what we do once we confirm USG, if there is an appendicular mass, we are gonna go for CT to confirm. Okay, so to confirm the position also, and if the definite thing is not available with respect to USG, we are gonna go for CT. Okay, then the management is based on the Oshner-Sherim regime. So what it tells is, if it is acute case of appendicitis, what we'll do is NPO. Okay, so will be nil per oral, and IV fluids is given. Nasogastric tube, that is the Rales tube, is inserted, and antibiotics is given. Okay, so this is the mainstay of treatment. And what we do is, we'll monitor the patient and give some painkillers to reduce the pain. Okay, then after a while, what we'll do is, after 6 to 8 weeks, we'll call them back again. After all this, we'll do the admission, and we'll try to control all these symptoms, and then we'll do the discharge, and we'll tell them to come back after 6 to 8 weeks, and we'll do interval appendicectomy. Okay, so this is the treatment that we do for appendicitis. This is mainly to prevent the rupture of appendix. Okay, so appendicular mass is there, so we'll prevent the appendicular mass rupture through this method. So that is why we should not too many times we should do the palpation and all. So that is why in medical colleges we used to not get as many times to, not all of us used to get to do the palpation for appendicitis, right? So this is the reason why it might rupture, and the peritonitis might happen. So then it will be an emergency. So what are the incisions that we use? So please go through the abdominal incisions, okay, all the incisions, the gridiron incision, the Finkelstein incision, all these things. So gridiron incision is what we do with respect to appendicitis surgery. There is Battle's incision and Lance incision. Please go through all the incisions that are required, okay. Then the differential diagnosis, we might be confusing Yersinia enterocolitica with appendicitis, okay. Yersinia enterocolitica also comes with similar symptoms of appendicitis, okay. What is happening is, here the ileum, cecum and appendix, all of this will be inflamed, okay, with respect to Yersinia enterocolitica. This is a differential diagnosis, okay. Please know this. So this is all and everything you need to know with respect to appendicitis disorders, okay. So now let us see some of the miscellaneous things with respect to the intestinal tract, that is all the small intestine and large intestine, and then we'll go to rectus and anus, okay. Then we'll be done with gastroenterology, okay. So the thing is, with the miscellaneous topic, there is something called as diverticulum, diverticulosis and diverticulitis. Meaning diverticulum, we saw it, right, Meckel's diverticulum. So it is a blind pouch, okay, communicating with the lumen. So best example is Meckel's, okay. So there are true and false diverticulums, okay. Then coming to diverticulosis, meaning there is many of these kind of diverticulums, okay. So it will be most commonly seen in sigmoid colon. How do we investigate is through barium enema, okay. Sawtooth appearance will be there. This is diverticulosis. There are many diverticulums will be there, so this is known as diverticulosis, okay. If there is an inflammation in the diverticulum, then that is called as diverticulitis, okay. So there will be inflammation, basically. There will be left lower quadrant pain. We told, right? So it is the lower end of the ileum, that is the terminal part of the ileum, most common site of Meckel's diverticulum. So that is why the left lower quadrant pain will be affected with respect to diverticulitis. There might be fever because it is an inflammation. So what do? They will do something known as Hartmann's procedure and resect the particular diverticulum. So this is what we do, okay. Then coming to one of the important topics, that is mesenteric ischemia and paralytic ileus, okay. So mesenteric ischemia can be acute and chronic. Here in acute, there will be SMA emboli, okay. So superior mesenteric emboli might happen and lead to small intestine necrosis, okay. So there will be increased exaggerated abdominal pain will be there with respect to mesenteric ischemia, okay. So the presentation other than abdominal pain will be red recurrent jelly stool will be there, okay. Then coming to chronic case, it is going to be celiac artery that is involved, and most commonly the SMA is also involved. Here there is atherosclerosis, okay, long term atherosclerosis was there, whereas here it was emboli, okay, sudden block is there. So the symptom will be postprandial epigastric pain, just like gastric ulcer, okay. We think that it is a gastric ulcer, okay, but it is the chronic ischemia that is happening, okay. So IMA is affected in colonic ischemia, where hematogexia, that is the red blood stool, can be seen, okay. So this is the difference between the two mesenteric ischemias. The other one, a very important one, is paralytic ileus, where just like we saw it in Hirschsprung's disease, right? Here also there is hypomobility without obstruction is there, okay. Hypomobility, so which causes the stool to stay there only, so which will lead to constipation and reduced flatus, okay. Which this happens because of so post-operative, okay, post-operative after laparotomy, okay. So there will be reduced bowel sounds, okay. So the management will be bowel rest, electrolyte correction, and the cholinergics can be given to let out the stored stool that is there, okay. So paralytic ileus, okay. Then coming to colonic polyps, there are two things, okay. One is non-neoplastic and neoplastic colonic polyps, okay. So please remember these two example, okay. So that is FAP and Peutz-Jeghers syndrome, okay. So they have been asking Pouch-Jigger syndrome and its extra-intestinal features. I'll come back to that. Okay, so non-neoplastic is hamartomas, whereas neoplastic is adenomatous. Okay, so the two best examples are Pouch-Jigger syndrome, and here it is FAP. Okay, then the genes involved are STK11 and APC gene, whereas here there is a reduced risk of cancer. There is very high risk of cancer with respect to, that is why the name neoplastic, right? Here it is non-neoplastic, it is a benign thing. So extra mucosal symptom is mucocutaneous pigmentation. Okay, so around the lip there will be bluish discoloration. You would have seen some questions, right? So even on Instagram and all, you would have seen some bluish discoloration will be there around the lip and all. So this is the Pouch-Jigger syndrome. Okay, so then the retinal features can be seen in adenomatous, that is not a neoplastic colonic polyp. Okay, then coming to toxic megacolon. So due to various colitis, this toxic megacolon might happen. So management will be basically conservative. Okay, so what we do is observation, and after observation, if it is too much dangerous, then we will go for laparotomy. Okay, so how will be the investigation? Basically will be X-ray, right? So it will look like a coffee bean. Okay, coffee bean with respect to sigmoid volvulus. Okay, toxic megacolon is a different thing. Okay, but here it will be the coffee bean with respect to sigmoid volvulus. Okay, it is similar to toxic megacolon only. Here it is sigmoid colon, that is inward, being inward. So in sigmoid, if the sigmoid colon is inward, we'll get to see coffee bean like appearance. Okay, so it will look like this coffee bean. Okay, so the sigmoid will look like a coffee bean. Okay, so just go see an X-ray of it. Okay, so please note, the colonoscopy should be avoided in toxic megacolon. It might exaggerate the symptom and it might become an emergency. Okay, so that is all with respect to all the intestinal pathologies. Now we'll move on to rectal disorders. So some anatomy with respect to rectum is, so anorectal angle. Okay, so anorectal angle is a puborectalis. Okay, so anorectal angle is a puborectalis. Now coming to the specific pathology of rectum is the rectal prolapse. The prolapse is what has been asked. Okay, so these years. So in rectal prolapse, we are gonna divide the cases as based on the age. Okay, so children, young and elderly. Okay, if it is going to be a child that is having the rectal prolapse, we are going to conservatively manage it, and if it is a young guy, it is going to be abdominal approach, and we'll do the suture rectopexy. Okay, so suture rectopexy is done, or we'll gonna be doing the mesh rectopexy, and we'll strengthen the muscles. Okay, then if it is elderly, we are going to go perineal approach, and we'll do something known as Dolorines and Thier's stitches. Okay, so please remember these two names, Dolorines and Thier's stitches, is what we are going to do for rectal prolapse. Okay, so then moving on to rectal cancer. Okay, the clinical feature will be perrectal bleed. Okay, hematochexia can be seen. Then adenocarcinoma is the most common type of carcinoma with respect to rectal cancer. So there are a staging that is done for rectal cancer. Based on staging only, we are going to manage. So basically Duke staging is what we do. Investigation is endorectal MRI. Okay, endorectal is MRI is done, and we'll do the staging of it. Okay, stages is based on endorectal MRI. So what is the surgical management is, so if the surgery is here, okay, it is the rectum. If the lesion is here, proximally 5 centimeter we are gonna resect, and the distally 2 centimeter till 2 centimeter is we are gonna resect. Okay, and radially it will be the 5 centimeter, around 5 centimeter of radial circumference we are gonna resect. This is how we are the surgical approach will be. Okay, then the chemoradiations will be given, that is FLFOX. Okay, FLFOX is for rectal cancer. Okay, now coming to the last thing, that is the anal disorders. With respect to anatomy, the venous drainage for anus is basically inferior rectal vein. Okay, then the inferior rectal vein will drain into the systemic veins. Okay, then inferior rectal vein, please remember this. Okay, because that is very important with respect to hemorrhoids and hemorrhoid management. So that is why inferior rectal vein is the venous drainage. So the lymphatic drainage is inguinal lymph nodes. Okay, so this is also very important. Inguinal lymph nodes, the two superficial inguinal lymph nodes is very important, because anorectal cancers might have the metastasis to inguinal lymph nodes. Okay, then coming to nerve supply of the anus, it is the inferior rectal nerve that supplies the anus. Okay, now the pathologies of anus is are hemorrhoids, that is piles, commonly called as. So this is basically the tortuous veins that is around the anus. Okay, so there is two types of hemorrhoid, that is external hemorrhoid and internal hemorrhoid. External hemorrhoid is basically below the dentate line. So suppose this is the anus, so there is something known as dentate line which divides it as external and internal anus. Okay, so if it is below the dentate line, it is going to be the external hemorrhoid, whereas if it is above the dentate line, it is going to be internal hemorrhoid. Okay, here there is no nervous system, so that is why there is, it will be, below the dental line there will be pudendal nerve and all. So that is why there will be increased pain with respect to hemorrhoid. So here the inferior rectal nerve and all will be there. So that is why it will be painful with respect to external hemorrhoid, whereas it will be painless if it is above the dentate line. Okay, the internal hemorrhoids. So grading will be done. So this is very important, grading. Okay, primary, secondary, tertiary and quaternary. So basically in primary hemorrhoid there will be bleeding, but there is no prolapse at all. Okay, so the tortuous vein will be not prolapsing out. Okay, then when it comes to secondary, it is going to be prolapsing but spontaneously reducible. Okay, so reduction is possible, whereas in tertiary prolapse is there, but the reducibility is based on manual reduction. Okay, so we have to reduce it. Okay, then coming to quaternary, it is going to be prolapse again, but it is not reducible at all. Okay, manually also it is not reducible. Okay, this is the quaternary. Okay, then coming to management, if it is less than 48 hours of pain that is occurring, it is going to be evacuation that we are going to do. Okay, so we'll remove that particular vein. Okay, so we evacuate that particular vein that is affecting. If it is more than 48 hours and it is a bearable pain, so what we'll do is we'll give some analgesics and we'll tell them to do sitz bath. Okay, so sitz bath, you know that, right? A bowl of or a tub of water, and we'll tell them to sit exposing the anus. Okay, so we'll tell them to sit exposing the anus. So this is how we tell them to do the sit bath. Okay, then grade 3 and 4, this is for grade 1 and 2, whereas grade 3 and 4, as it is prolapsing and reducibility is very difficult, here we are going for hemorrhoidectomy. Okay, so based on the grading is how we do the management. So hemorrhoidectomy is what we do it. Okay, then coming to anal fissures, it is going to be acute and chronic type. So most commonly it will be in the posterior midline. So anal fissure is just a wound that is happening in the anal canal. Okay, in the acute anal fissure, it is going to be, the clinical features will be the pain, bleeding on defecation will be there, whereas chronic, there will be a sentinel tag. Okay, and the ulcers might have happened. Okay, sentinel tag might be there, so and ulcers might be seen. Okay, how do we manage is basically topical applications that we can give for wound management in acute cases, whereas in chronic cases we'll have to do internal lateral sphincterectomy. Okay, so and what we do is basically we'll do the sphincterectomy so that the sphincter will be relaxed and there will be a proper defecation and the fissures will be not formed. Okay, so this is what we do in chronic cases. Okay, then the last thing, that is anal fistula. Please go through the types and images with respect to anal fistulas. There is a extra sphincteric here. For example, if there is a sphincteric, extra sphincteric can be there, suprasphincteric can be there, then transsphincteric can be there. So these are the types of anal fistulas that might happen. Okay, there is something called Goodsall's rule. What it tells is the anterior ones. Okay, suppose this is the anus, and if this is the posterior and this is the anterior, what it tells is the anterior ones will be okay, so radically straight. Okay, so radially straight it will be there. Okay, the openings. Okay, so the internal opening and the external opening will be straight, whereas the posterior ones usually will be curved. Okay, so it will be curved. Okay, this is called as Goodsall's rule. Okay, the other ones are the intersphincteric and submucosal anal fistulas will be there. Please go and see the types of anal fistulas and the openings that is there. Okay, what do we do? The management will be Stenson's technique. Okay, since Stenson's technique, we'll introduce a probe and we'll try to resolve it. Okay, this is how we will treat the anal fistula. So this is all and everything you need to know with respect to gastroenterology. So next on we'll go and cover the hepatology. In hepatology we'll be covering hepatology, pancreas and the gallbladders. Okay, so this is with respect to gastroenterology. Okay, thank you.